very much دكتور كريم. أنا عايز أشكر الحقيقة كل زمايلي وأساتذتي في قسم الباطنة، وشكرا على الدعوة الكريمة، وبشكر سانوفي على برضو دعوة in their symposium to talk about a very important subject often forgotten. في خلاف ودبيت هي رار ولا هي احنا ما بنفكرش فيها، بس مش محسوم، بس ممكن by the end نشوف. It's an esophageal problem and I'll go straight into details من غير فوازير. We're talking about eosinophilic esophagitis. وبس نفرق ما بين eosinophilic esophagitis and esophageal eosinophilia. Eosinophilic esophagitis is a disease. حصل inflammation due to an antigen, والinflammation that triggered a type 2 response. والtype 2 response is a slow response مش like proactive pro-inflammatory type 1. type 2 slow reacting لغاية لما يوصل ان هو يعمل تغييرات وريموديلنج في الميكوزا بتاعت affected area. In case of esophagus ممكن يحصل remodeling up to rings and stricture formation that may need dilatation. أنا بنسى إني عجزت وبقيت محتاج النضارة لغاية لما اكتشف الدنيا نورت كده. أوكي. التايب 2 ريسبونس ده بيحصل من allergen قدر يخترق الميكوزال بارير. الانتجريتي اوف ذا ميكوزال بارير واز بريتشد، فاخترق انتيجين او في الحاله دي allergen، وال TH2 response was provoked interleukin 4 and interleukin 13 mainly. راحوا على السيل ممبرين وبداوا يديليفر الترانسكريبتيز مسج inside the cell علشان to induce the TH2 response. It is not a very highly prevalent disease, but the incidence is getting higher and higher rapidly. لكن to date نقدر نقول إن globally 1 in every 1,000 patients suffers eosinophilic esophagitis. The disease comes with a lot of burden, the symptoms of the illness, impaired health quality of life, progressive symptom impact daily life, relapse, recurrence of symptoms. Also, of course, there is an economic burden, the cost, so a direct cost على البيشنت أو an indirect cost على economy. It does come with quite a lot of burden. Why is it early to diagnose eosinophilic esophagitis? First, to diagnose eosinophilic esophagitis, I have to think about it. لأن هي ممكن by just simple endoscopy ما نلاقيش حاجة. So why is it important to discover early? أولاً, knowing that for every year of undiagnosed eosinophilic esophagitis, there is a 5% increased risk of fibrostenosis, and there is a 9% increased risk of stricture. Also, an increased risk of food infections because of the strictures, having to go to the ER quite oftenly. About 19% of patients with eosinophilic esophagitis have at least one ER visit in a year, so that's quite a number. عشان كده محتاجين to diagnose the disease early enough before reaching the stage of stricture. As I said, this is just a scenario of a patient coming complaining of certain symptoms like feeling difficulty in swallowing. Usually this is the main symptom. Chest pain not associated with eating. Itchy mouth sometimes, and this could be because of a food allergy. Anxiety, occasional vomiting. The symptoms here كلها non-specific. So I have to know the right questions that I should be asking. And the important questions are 4 questions. Does food get stuck when you eat? لأنه ممكن هو يحصل له food impaction and present PR, so this is a straightforward presentation. لكن ممكن ما يحصلش ده، لكن البيشنت بيشتكي من difficulty in swallowing أو بيشتكي even من الفود بيقف شوية وبعدين بياخد وقت few minutes until يشرب حاجة فيبلع. So this is a very important question. Another question is, do you need to cut food into small pieces برضه علشان يحسن البلع؟ Do you need to always drink with meals برضه عشان يحسن البلع؟ Do you need to make crusty bread softer يعني ما تقدرش تاكل الحاجات الناشفة. So those are the 4 variable questions I should be asking the patient whenever I'm considering a diagnosis of eosinophilic esophagitis. طبعا بيبقى معاها comorbidities most likely مش a single disease, comes with allergic rhinitis, food allergy, asthma, and atopic dermatitis. So it's always a variable question في history taking إن أنا أسأل عيان about any atopy. Atopic patient, I should be thinking more of eosinophilic esophagitis than non-atopic ones. So this is endoscopically what we can see. And we used الوصف بتاع endoscopy to develop a scoring system, E-REFS, E for edema, rings, exudates, furrows, and strictures. And of course, I have to add إنه ممكن endoscopic picture في eosinophilic esophagitis يبقى just completely normal esophagus. لكن according to this, I give a score for each ويبقى عندي scoring system because زي ما احنا متعودين في الجاستروenterology أو في الاندوسكوبي we always try to develop classifications and scoring systems عشان نبقى speaking the same language. Again, the patient, it's very important to say الهيستولوجي بقى. لما رجعنا للبيشنت بتاعنا والبيوبسيز بتاعنا لقينا الهيستولوجي was still not available. It is important اللي يبقى عندنا histology الحقيقة عشان الاكيوريت diagnosis despite a normal esophagus. يعني ممكن بالباثولوجي لو لقيت endoscopic lesions هاخد biopsy. This is always tempting. لكن you have to remember to take biopsy even in normal looking esophagus. 10 to 15% of adult patients have eosinophilic esophagitis despite of a normal endoscopy. Up to half of adult patients with dysphagia or esophageal food impaction have eosinophilic esophagitis based on esophageal biopsies. So biopsy is very important واللي بدور عليه في biopsy هم الايزينوفيلز اللي هم النقط الحمراء دول. My pathologist tell me انه بره provide صور الباثولوجي اللي فيها اكتر number of eosinophils per high power field علشان انا اقدر اراجع ورا الباثولوجيست اشوف هو شاف كام واحده. الكات اوف ليفل برضه كان ايشيو محير شويه، مش عارفين. في ناس قالت 15 ده الرقم اللي هم اتفقوا عليه في النهايه، ان كات اوف ليفل اوف 15 eosinophils per high power field is diagnostic or let us say highly subjective لان في الاخر it's a clinical pathological diagnosis. And back to the patient, how do we confirm a diagnosis lately? It's a multidisciplinary and it's a clinical pathological diagnosis. We have to consider the clinical presentation of the patients that might be suggestive of eosinophilic esophagitis. We have to do endoscopy and take biopsies, normal mucosa or not. We have to measure the eosinophils per high power field, and we have to rule out other diseases like reflux, of course, and then we finally have a diagnosis. How about the management? It is not an easy task to manage patients with eosinophilic esophagitis because there is no one drug that is completely wonderful. So we always have to define what am I looking for, what am I trying to do, what I'm reaching. So the goals of treatment is eliminate the disease symptoms, prevent the symptom relapse, improve quality of life, normalize and maintain esophageal histology, normalize and maintain endoscopic appearance, resolve esophageal inflammation, more likely like all the chronic inflammatory diseases of the bowel, like IBD. I'm looking for clinical response, I'm looking for endoscopic, mucosal response, and histological response. Is this achievable in eosinophilic esophagitis? Well, we use for treatment to date is the proton pump inhibitors, the swallowed topical corticosteroids, and elimination diets. PPIs were quite valuable, but 30 to 40% of patients with eosinophilic esophagitis will not reach remission. Topical steroids is a lot better. Histologic remission in up to 2/3 of the patients, it is not available in Egypt. And of course elimination diets, ودي بقى قصة كبيرة جدا مع الدكتورة منى يقول لنا الدايتس اللي ممكن نجرب نعمل لها elimination بسيستم معين in cases of eosinophilic esophagitis. Until recently دي طبعا limitations unmet needs proton pump inhibitors 66% to 100% will relapse after 1 year while the patient is still on treatment. And in topical corticosteroids, 82% of patients experience relapse after cessation of therapy, then we cannot maintain on steroids. More than half of patients had symptoms recurring within 1 year of discontinuing the treatment. فطبعا we have also mechanical management by balloon dilatations which are done more than one time in cases of stricture. And we know that a portion of patients with eosinophilic esophagitis may not respond to initial pharmacological treatment, so those are the unmet needs. Diet therapies برضو ممكن ما تبقاش feasible because of the challenge of adherence. Adherence to a diet regimen is quite an issue here for patients. And many patients relapse after discontinuing the therapy. So what do we have? Biologics. Magic that we are using more oftenly lately. So we have the dupilumab from Sanofi. The dupilumab is an anti-interleukin 4, anti-interleukin 3. What happens is when the allergen passes the epithelial barrier in the interstitial space develops the response, the Th2 response mediated by IL-4 and 13 in cases of eosinophilic esophagitis, others in cases of whatever else disease. So interleukin 4 and interleukin 13, they go to the cytokine receptor on the cell and they trigger the inflammatory response passing into the cell through an intracellular portion of the cytokine receptor. This is the extracellular portion. This is the intracellular portion. The interleukins activate the outer surface of the cytokine receptor, and then the JAK inhibitors activate inside the cell. Basically what happens is there is a transcription message, a genetic transcription message that needs to go to the cell and to the nucleus of the cell. This cascade of inflammatory response makes sure that the message is delivered to the nucleus. So the dupilumab is used to block the cytokine receptor for interleukin 4 and interleukin 13, rendering them unable to penetrate and unable to initiate a response. Dupilumab indications, of course, we are talking now about the dupilumab indication for the treatment of adult and pediatric patients aged 12 years and older, weighing at least 40 kilograms with eosinophilic esophagitis, with the أحدث indication. But before that, it was already approved for adults and adolescents with moderate to severe atopic dermatitis and severe atopic dermatitis in infants and children 6 months or above. Also, dupilumab is indicated in severe asthma with type 2 inflammation and in cases of chronic rhinosinusitis with nasal polyps for whom therapy with corticosteroids was not effective. So quite a number of indications of dupilumab, the latest of which is the eosinophilic esophagitis. And this is the study, the Liberty study. Based on it, the dupilumab made it to approval. And very simply, the study was comparing dupilumab with single dose or double dose per week with a placebo, and then replacing the placebo in part C of the study to assess long-term effects. And on histology, of course, very significant dupilumab from the placebo. Also the same significance with dysphagia scores and endoscopy. And part C for the long-term management, we can see that the patients had a very satisfying long-term management compared to placebo. So based on this study, dupilumab was approved, and for the adverse events, nothing major. The main adverse events occurring in less than 10% of patients was actually the injection site reaction, nasopharyngitis, injection site erythema, headache, and rash. And most of those were, or all of those were reversible. Lastly, Sanofi just wanted to declare that there is a new indication for dupilumab, which is approval as a first and only treatment indicated for children aged 1 year and older with eosinophilic esophagitis. Before, the approval was for children aged 12 years and older. So the new indication is children aged 1 year. This is your message, sir? Sanofi. Okay. Thank you very much.